Next comes the vocal cord paralysis. It may be unilateral or bilateral due to birth trauma or congenital anomaly of the great vessel. Birth trauma during breech of forceps delivery, recurrent laryngeal nerve is stretched. As a result, respiratory obstruction and stridor absorb. And the treatment is tracheostomy if there is severe respiratory obstruction. And laryngeal paralysis. Laryngeal paralysis is due to recurrent laryngeal nerve, superior laryngeal nerve, and combined. Recurrent laryngeal nerve has two branches, sensory and motor. Sensory supplies below the vocal cord, and superior laryngeal nerve also has two branches, sensory and motor. Sensory supplies above the vocal cord. Motor supply is to all muscles except the cricothyroid, whereas superior laryngeal nerve supplies only to the cricothyroid muscle. Recurrent laryngeal nerve paralysis is again of two types, unilateral or bilateral. Unilateral, mostly they are asymptomatic, only a change in voice is seen, and the treatment, it is advisable to wait for at least 6 to 12 months as a compensation of the healthy cord restores the voice, or else laryngoplasty type 1 or thyroplasty type 1 is done. It is nothing but medializing the cord. Along with this laryngoplasty type 1, arytenoid adduction is done if posterior glottis is incompetent. If posterior glottis is incompetent, arytenoid adduction plus laryngoplasty type 1 is done. In coming to bilateral, clinical features are inadequate airway and dyspnea, stridor. Due to inadequate airway, there is dyspnea, stridor, and the vocal cord position is median or paramedian. Paramedian is 1.5 mm to the median position of the vocal cords, 1.5 mm. And cadaveric position is 3.5 mm from the median position of the vocal cords. Treatment, as there is inadequate airway, tracheostomy if it is severe, and transverse chordotomy. Transverse chordotomy is between the membranous cord and vocal process of the arytenoid. A transverse part is cut. This is called transverse chordotomy between the membranous cord and vocal process. Transverse chordotomy. Then partial arytenoidectomy. That is, medial part of the arytenoid is removed. Partial arytenoidectomy, that is, medial part of the arytenoid is removed. Thyroplasty 2, that is, lateral displacement of the cord. And reinnervation procedures, that is nothing but omohyoid muscle with along with its nerve supply is implanted into the thyroarytenoid muscle. Omohyoid muscle along with its nerve is implanted into thyroarytenoid muscle. Tracheostomy, transverse chordotomy, partial arytenoidectomy, thyroplasty 2, and reinnervation procedures. Coming to superior laryngeal nerve paralysis, mostly it is a part of combined paralysis, and causes are neuritis or tumors, whereas in recurrent laryngeal nerve paralysis, the causes are mostly due to thyroid surgery or thyroid enlargement. Unilateral and bilateral. Unilateral, there is weak voice and pitch is not increased during singing, mostly during singing. Weak voice and pitch not increased. Here weak voice plus food inhalation is food inhalation. On examination, the cord is of wavy type, wavy. So you can remember here, and other feature is on inspiration the cord sags down, on expiration it bulges. So if you remember this, you can remember the second point, that is sags down on inspiration and bulges on expiration. Anterior commissure. Anterior commissure is the region between the two vocal folds in the anterior part. It is called anterior commissure and it rotates to the healthy side. In bilateral, and treatment is tracheostomy and epiglottopexy. Epiglottopexy is Closure of the larynx inlet to prevent food inhalation. By technique like epiglottis is fixed to adenoids. This is a temporary procedure. And combined paralysis. Recurrent laryngeal nerve plus superior laryngeal nerve paralysis. It is again of two types, unilateral and bilateral. The side affected. One side is affected. There is anesthesia or no sensation and paralysis of all muscles except interadenoid muscle because it receives nerve supply from other side also. Etiology, thyroid surgery, which is common. Vocal cords are in cadaveric position, that is 3.5 mm from the median position. And clinical features of unilateral are AHC, like PHC, primary health center, you can remember AHC if you want. A for aspiration, H for hoarseness of voice, C for cough. Here ABC, aphonia or aspiration and aspiration, B for bronchopneumonia, C for cough. Here in unilateral cases there is hoarseness of voice, speech therapy and thyroplasty 1 is done. In bilateral, aspiration is a common feature, so epiglottopexy is done, that is epiglottis fixed to arytenoid, and vocal cord plication, that is true vocal cord mucosa and the false vocal cord mucosa are removed. And tracheostomy. There is a diversion procedure. Diversion procedure is between T3 and T4, between T3 and T4 cartilages. It's cut between T3 and T4 cartilages and the upper part is connected to esophagus and the lower one acts as a tracheostome so that the food which inhaled enters into the esophagus. Gastrotomy may be done. Total laryngectomy can also be done. Thank you.